In this session, we're looking at a lung specimen from a 73-year-old male who had asbestosis. Whilst he died from acute respiratory failure, post-mortem analysis revealed carcinoma of the lung with extensive dissemination. It is unknown whether the patient smoked or not. Macroscopically, we can see widespread pulmonary fibrosis throughout the lung, particularly in the subpleural and interstitial regions. This is, however, most notable in the lower lobe, where a whitish-colored nodule is visible. There is also evidence of lung collapse, as you can see here. The black pigment throughout the lung parenchyma is inhaled carmine. From the back, you can also see that most of the bronchi contain impacted mucus, which is clear evidence of gross systemic lung dysfunction and inflammation. There is also evidence of dense fibrous pleurisy, as you can see here, here, and here.
We will now discuss the microscopic appearance of asbestosis. The slide we see here was prepared by staining a biopsy of the lung tissue with hematoxylin and eosin. At low microscopic magnification, you will be able to see large areas of interstitial fibrosis, which ablate the alveoli or degrade their air exchange function. Several of the adjoining air spaces show severe dilation and destruction from an inflammatory process similar to that seen in emphysema. There is also evidence of macrophage accumulation within the alveoli. The pleura is fibrotic and much thickened, and some of the vessels in the pleura are significantly congested. Contraction of the fibrous tissue distorts the native architecture, creating large air spaces enclosed with thick fibrous walls. In this way, the affected regions, usually the lower lobes of the lung, become honeycombed. Some bronchioles will have developed a stratified epithelial lining as evidence of metaplasia. Within the alveoli, you will be able to see some brown and elongated asbestos bodies. These are inhaled asbestos fibers that have been coated with hemosiderin and macrophage-derived protein, and they arise when macrophages attempt to phagocytose asbestos fibers. The hemosiderin is derived from digestion of red blood cell hemoglobin by the macrophages in the alveoli. Red blood cells extravasate into the alveoli from blood vessels made leaky by the ongoing inflammation and pulmonary hypertension. At a high magnification, we can see that some asbestos bodies have been almost entirely engulfed by multinucleate giant cells. Notably, these asbestos bodies present the only method of distinguishing asbestosis from other causes of diffuse interstitial fibrosis. Note the bead-like brown coating of hemosiderin on the asbestos fiber within the giant cell. Also note the extreme congestion of blood vessels as well as the free red blood cells in the alveoli. This is due to ongoing inflammation and pulmonary hypertension.